Ma'am, we are on live now, ma'am. I'm starting session.
Yes, sure.
Yeah, ma'am. So, good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's webinar is management of trauma during pregnancy. I welcome all the participants. I request them to post their queries in the chat box so that we can have a short Q&A session at the end of this presentation. And now it's time to introduce our invited speaker for the day, Professor Hephzibah Kirubamani, ma'am. Madam is currently the professor of OG, Savita Medical College, Chennai. Madam was also the former president, Government RSR Medical College, and Professor Stanley Medical College. Madam has done her MD, DGO, and PhD. Madam was the past president of Obstetrics and Gynecology Society of Southern India, vice president of Chennai Menopause Society. Interested in awareness programs in radio and TV channels. Madam has also conducted awareness programs for Tamil Nadu paramedical staff, schools and colleges. Madam has received various awards like A.L. Mudaliar Award, a Lifetime Achievement Award from TNMGR University, Dr. APJ Abdul Kalam Award, and Tamil Nadu Medical Council Award for Medical Excellence in Teaching from His Excellency Government Tamil Nadu Governor 2018. Madam has also developed a midlife and beyond medical app for IMS. Madam has written various textbooks, and Madam has also various journals published in international journals. So with this short introduction, I welcome you, ma'am. I'm handing section to you for further proceedings, ma'am. Thank you, ma'am.
Yeah. Shall I share my screen?
Yes, ma'am.
Are you able to see my screen?
Ma'am, it's sharing, ma'am. Yes, ma'am. Now we can see, ma'am.
Okay. Yeah, at the outset, I thank the Shield company for asking me to share few of my thoughts on management of trauma during pregnancy. I thank Dr. Stalin for his effort. And today's topic will be a management of trauma during pregnancy. Actually, we are the only specialty where we take care of two patients simultaneously. That I'm really proud about it. Two patients, we are treating them simultaneously. So when something happens to the mother, the jeopardy also doubles. That is the thing we are going to share. So moving on to the topic. Yeah, I will be covering you another 20 to 25 minutes. What is the incidence? What is the anatomical, physiological changes in pregnancy? Its clinical significance, how it is important in resuscitation, impact of on pregnancy and fetus when something happens, trauma, and how to do an initial quick assessment, and then the emergency management. So the trauma is also can happen during pregnancy. It is about 6 to 7% the incidence, and it can be the leading cause of non-obstetric death. The maternal death is the common cause for fetal death. So when we look at the incidence, because overall 7% of all pregnancy can end up in trauma, and 8% when they get involved in trauma, they do not know that they are pregnant. So the most common accident or trauma is due to motor vehicle accident, 55%, and 22% is due to fall, and 22% due to assault by an intimate partner or some other violence, and others 1%. And when we look at the mortality, it can be a mild, moderate, or severe. Based on the trauma, the fetal mortality rate varies. It can be minor, 80%, around 80% it is minor trauma, and 9% is moderate trauma, and 2% is severe trauma. When it is severe, the mortality rate, fetal mortality rate ranges to 15%. And maternal mortality also rise up to 3.5. Overall, the fetal death due to trauma is 1 in 30,000 pregnancy. So look at the types of trauma in pregnancy. It can be a road traffic accident, it can be an assault, due to domestic violence, by an intimate partner violence. There is a fall due to fall and pedestrian pollution, penetrating injury, usually due to gunshot injuries, sometimes suicide and homicide, substance abuse, and electrical injury, burns. See, actually, one of the patients, she came with the high BP with the fits, but so those days we used to treat them in a dark room and we were treating it as an eclampsia. But when we put on the light or something, there was a big mark in the neck and she has made an attempt for suicide and that hypoxia is causing the fits. So the suicide also can cause, she can have a hanging and then she can fall, something like that. So the commonest is the motor vehicle accident when they don't wear the seat belt or when they don't wear the seat belt properly, 33% maternal mortality. So it should cross in between the breast and it should come below this. Otherwise, there is no use. See here, this all is wrong, right? So that is very, very important thing. So how does it cause the impact of MVA, motor vehicle accident in pregnancy? So when it happens in two types, actually the uterus is thrown forward against the anterior abdominal wall and the body is pushed into the seat. So it's something like a shearing effect, shear failure. And the next type is the tensile failure. There is an enough negative pressure in the posterior uterus to pull the placenta off the uterine wall. That is something like a contrictive injury. So they will end up with a very high positive pressure anterior parts of the uterus. So it will just cause an abruptio and it is very dangerous. So why they fall? They are more prone for falls. Pregnant women are more prone for falls because there is a shift in the center of gravity, lumbar lordosis. So as the pregnancy advances, make the woman prone to fall and accidents. So when there is a trauma, there should be a team effect. The ER, you have to put that this thing, emergency call, and everybody has to assemble immediately. The code number, as per the code number. The trauma surgeon should be there, obstetrician, anesthetist, neonatologist. In trauma, there is a team, multidisciplinary approach is mandatory. So I was talking to you anatomical and physiological changes and its importance. See, as you all know, the plasma cell volume increases, red cell mass increases, cardiac output increases. All this, even with minute blood loss, there is a reduced maternal resistance to blood loss. So when there is a uteroplacental shift, so uterine injury may predispose to increased blood loss. So, and it's similarly uterine size, they are more prone for injuries, change in the abdominal contents. See, the intestine, something and all will be on the sides. So that can, in a penetrating injury, that can get injured. So, and because of the uterine enlargement, as such, they are more prone to hypertension. When there is a bleeding, there is a profuse fall in BP. So the respiratory system also is altered. So there is a diminished partial carbon dioxide, this thing, and there is a less buffering capacity. The functional residual capacity is decreased. So they are more prone for hypoxia. The gastric emptying is less. When something happens with the full stomach, they can and become little unconscious. They can aspirate the entire content. They can go for atelectasis. So our goal of treatment is save the mother. The prime thing is to save the mother and save the fetus if possible. Okay. So what are the steps? The primary survey, there should be a quick assessment from head to foot, both for the mother and the fetal status. And simultaneously, we have to resuscitate. And by doing resuscitation and second look, we have to review. Sometimes we can pick up few physical signs. And then by the time we can have a definite treatment, what to do. The save the mother is the first goal. We should do it. And whether to cesarean will help her out, or sometimes the patient can come with a splenic rupture. So she may require a laparotomy. So all these steps should take place in a quick manner, the quick examination and simultaneous resuscitation is very important in ER itself. So what is the initial assessment and the goal? The systolic blood pressure, at least we should raise up to 80 to 100 millimeters of mercury, and oxygen, carbon partial oxygen should be more than 90%. Hematocrit should be 25 to 36. Platelet count should be more than 50. And electrolyte should be maintained. Body temperature should be maintained. Serum lactate level we should check, and it should avoid metabolic acidosis. And adequate analgesia, our aim should be to give adequate analgesia also. So the best thing is the position. There should be after 20 weeks, a pregnant lady with a trauma, she should be with 30 degrees left tilt. So we have to replace quickly 3:1 crystalloid, and if necessary blood transfusion. And remember, the maternal BP and pulse rate is not reliable indicator for maternal and for fetal well-being. So the acute blood loss can occur, and blood flow decreases the main supply, maintaining the BP. So the signs and shock appear when there is a severe shock. The fetal compromise is more. So this is how we have to resuscitate them. The supine hypertension will increases the hypertension. So we have to tilt the left tilt. The main principle guiding therapy must be that resuscitating the mother. And it is sometimes it's very difficult to give a cardiac massage also. So there is a left lateral tilt. In that position only we have to resuscitate to avoid the supine hypertension. So quickly, after initial resuscitation, the secondary survey is to do the top to bottom physical assessment and extensive fetal evaluation we have to do. And you have to look for any bleeding, rupture of the fetal membrane, signs of abruptio, preterm birth, direct injury or a fetal injury, fetal distress. And we have to assess to some extent the fetal maternal hemorrhage. So, and the laboratory test, we should send it, as I already told you, serum electrolyte, complete blood gram, blood sugar, and don't forget to do the typing and RH typing, because we may have to do anti-D also. So urine analysis and ABG, these are the laboratories. Quickly we have to get the report. So to assess and managing the pregnant patient is ideally with the ultrasound. Not only for fetal evaluation, it helps to find out other conditions. If there is an internal hemorrhage or any other viscera is torn. So there should be a continuous fetal monitoring with the ultrasound and CTG measurement to assess about the liquor, abruption, etc. And ultrasound, we can find out not only about the mother fetal condition, we can find out if any fluid or collection in the abdomen or under the diaphragm also we can find out. And imaging studies, just because she is pregnant, we shouldn't think 100 times to shift her to X-ray or a CT or something like that. Though there is a radiation risk, we should not avoid or delay necessary exams, because we should do quick assessment, imaging studies. It's very, very important. Less than 5 rods is not going to affect the, and distance more than 10 centimeters does not going to affect the fetus at all. And less than 1% of trauma patients are exposed to more than 3 rods. So the fetal effect is very, very less. Even if there is a fetal risk, the prime importance is for the mother. So the CT scan gives very less, 1 rod, and abdomen above uterus 3 rods, and pelvic is 3 to 9 rods. And MRI does not have any effect on the fetal. So diagnostic imaging, we should not wait. So we have to continue to do that. So this is the thing which will help us the fast, that is focused assessment with sonography in trauma, that is called FAST. Quickly we have to do quick assessment. So this will reduce the need for X-ray. It shortens the time to surgery to decide about it. I told you the splenic rupture, quickly we made it. And 96% of the grave trauma patients require no test using ionizing radiation. So this fast assessment of sonography in trauma is almost 94% to 100% specific, and sensitivity is 83%. We can make a diagnosis. Nowadays, this diagnostic peritoneal lavage is very, very less with the advent of imaging and fast. So Previously, we used to do this thing, evaluating the intraperitoneal hemorrhage by putting a needle. Now it has been reduced to such an extent because of the fast assessment with the sonography trauma. So this is in nutshell, the primary surveillance, we have to be assessing the ABC, airway, breathing, circulation, stabilizing the patient with a tilt, left lateral, and quickly evaluate secondary surveillance so that we know so that we can arrive at what is the treatment part of it. And we have to do the investigation simultaneously and continuous assessment of the fetus with CTG, ultrasound, and vaginal examination to rule out premature rupture of membranes, preterm, and abrupture. So, anesthetist part of it, they have to maintain good anesthesia, oxygenation, normotension, avoid ketamines, monitor the effects if practical. Loss of variability is normal. Actually, when there is hypotension, there will be a loss of variability in the fetal heart. But tachycardia, bradycardia is a sign of hypoxia. And they should avoid certain drugs. So this, as I already told you, the complications will be placental abruption, premature rupture of membranes, preterm birth, ruptured uterus, fetal death, and 3.9-fold increase in DIVC, disseminated intravascular coagulation. So the severity of the trauma does not always accurately predict adverse fetal outcome. 60 to 80% of fetal loss result from relatively minor trauma. When there is minor trauma, we fail to have a vigilant watch either on the mother or the fetus. So the rupture of membrane with a mild insult or a trauma can occur after 4 hours. She can get into labor within 4 hours of injury. Placental abruption can occur after 72 hours, and fetal death can occur after 7 days also. So we have to monitor them carefully even if there is a minor injury. So that can be 3 varieties. The condition can be a mother is stable, fetus is also stable, condition is stable. Another condition, mother may not be unstable, the fetus is stable. The third variety is both of them are unstable. When the mother is stable, fetus is stable, she should be stabilized, and we have to monitor the fetus carefully. And there is not much of fetoplacental hemorrhage or this thing, but they need to have a still monitoring, vigilant monitoring, especially for the fetus, because something can happen after 72 hours, after 7 days, all that. So when the mother is stable, but fetus is unstable. So if the patient condition is fit, and if there is a period of viability, then quickly we have to do a cesarean section, especially if there is a uterine rupture, placental abruption, and fetal malpresentation. So all this fetal distress, when there is after 32 weeks, if the mother is stable or if it is stabilized, fetus is unstable, we have to do a quick cesarean section. When mother and the fetus is unstable, the primary focus should be on the maternal care. Whenever there is an injury, you have to take care of them. Even in fetal distress, as critically injured, the mother will not withstand cesarean section sometimes. Early restoration of the maternal physiology automatically take care of the fetus also. If the mother can withstand cesarean section, then it can be performed. So there is a place called peripartum cesarean section. Okay, when the mother is critically ill, when the resuscitation is done with all ACL's guidelines, in spite of that, there is no response after 4 minutes, then we can decide about the peripartum cesarean section. It should be done even in the emergency room. Quickly, we have to deliver the fetus. In spite of resuscitation, we have to deliver the fetus by putting a vertical incision and remove it. So the common pitfalls in the management of obstetric trauma is the failure to suspect or recognize shock despite normal vital signs, because they can balance to some extent because of all these physiological changes. Failure to suspect visceral injury. I told you, see, invariably the domestic violence, this men will hit against the abdomen. The ladies will be sitting down or on the floor. So the malaria spleen can give way very easily. So So failure to recognize and treat supine hypertension syndrome, failure to suspect and screen domestic abuse, failure to recognize early pregnancy. She may be in 8 weeks, she may not even know that she is pregnant. So routinely you have to ask for LMP and routinely to do the urine pregnancy test when any lady in reproductive age group comes. Failure to observe fetal heart and viability in minor injuries, failure to test RH status and administer anti-D. So to sum up, the management, assess the maternal status, cardiac arrest and other things, ACL guidelines should be followed, advanced life support, that is A, B, C, breathing, circulation and other things. So quickly you have to do all the laboratory tests and treatment. If there is an abruption, based on that, you can assess quickly. And based on that, the management depends upon that. If the maternal injury is minor and bruising or laceration or contusion, when it is present, so consider IV access, basic investigation. If you have to assess the fetal condition with a Doppler or ultrasound. Treatment, if it is there, if suppose even minor injury can cause abrupt shock, based on that you have to treat. When minor injuries, there is no minor injuries, but history of assault or something like that, you have to do continuous monitoring, the fetal assessment. No need for lab evaluation. No radiological imaging is done. Patient counseling, but we have to have an eye on the fetus and the mother. So when the fetus is viable, fetal monitoring along with the management is essential. So it can be, trauma can be due to motor vehicle accident, it can be due to slip, it can be due to burns. So it can be due to depression and suicide. It can be a penetrating gun injury or something, a toxic substance they can take. So all this, so when they have a suicidal tendency after resuscitation, we have to put them on counseling and other things. So how to take care of the fetus? When it is more than 24 weeks, when it is less than 24 weeks, we can to some extent ignore the fetus. The primary will be the maternal survey. So if the FH is there and more than period of viability, then secondary maternal survey, maternal resuscitation. Then when there is an arrest within 4 minutes, if it is not responding, we have to do an emergency peripartum testing. Here, when the patient is stable and the FH is unstable, we have to do emergency section. So to conclude, the key points will be all reproductive age female, when the trauma is there, they should have a pregnancy test. Generally, medication test, treatment and procedures required to stabilize the mother should not be withheld because of pregnancy. Oh, in pregnancy, this is contraindicated, this is contraindicated. First, the mother, we have to life-threatening condition, we have to save. So the pregnant woman after 30 weeks should be placed, not even 30 weeks, 24 to 28 weeks, in lateral decapitous position and in lateral tilt to prevent supine hypotension. Even in minor injury, careful and prolonged monitoring the fetus is required. Always evaluate for possible pregnancy-related cause of an accident. Seizure secondary to eclampsia. I told you, no, we thought it is eclampsia, but basically it is a suicide, which has got hypoxia and fits. So the most diagnostic and therapeutic modalities relating to trauma care should not be modified or avoided during pregnancy. Certain drugs which is contraindicated, but it's a life-saving procedure, we have to do it. And multidisciplinary approach is very, very essential for a trauma victim and care for her fetus. So the maternal life takes the priority. In case of trauma, it takes the priority, the maternal life. The best chance of fetal survival is the maternal survival. When the mother is okay, the fetus is going to be okay. The initial management should be as per advanced life support, ATLS. Imaging should not be withheld if it provides a significant diagnostic information. Simple, I told you the fast. So the imaging modality helps us so quickly to arrive at the diagnosis. See, one patient went in for coma just because the ectopic was missed. Okay, so the imaging is very, very useful. So The trauma, when the patient comes, it is a unique challenge because we have to take care of two patients. And in addition, there is an altered physiology. There is an altered response when the patient is trauma, not like non-pregnant patients. So it is really a challenge to face such conditions. Challenges are what make life interesting. Overcoming them is what makes life meaningful. And thank you for patient listening. So with all our effort, the mother, fetus, and the husband is very happy. Thank you for patient listening.
Thank you, ma'am. Thank you very much for that informative session, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, I will read it for you, ma'am. Ma'am, I have personally some two questions, ma'am. Whether during, if there is any trauma and if there is excess blood loss, whether blood transfusion can be given for these pregnant ladies,
Yes,
and
yes.
what will be the impact, ma'am? Whether it will be having any impact on this
When the
fetus?
patient is shocked, first we have to resuscitate with the 3:2 crystallite and this thing. If there is a blood loss, blood for blood, no harm in giving blood. When the patient is having 6 grams and there is a profuse bleeding, and you do not know from where she is bleeding, we have to transfuse. Sometimes we need to have massive transfusion. There is no this thing. Sometimes they quickly go in for DIVC, so 1:1:2. FFP also, packed cells, FFP also we have to give. Platelet also sometimes we have to give because platelet should be maintained at 50,000 at least.
Ma'am, whether it will be having any effect on the immune system, madam, whether the...
Nothing will happen. She is in shock. The blood is, there must be some oxygen, RBC to carry some oxygen to the tissue. Where is the immune system is going to alter? There is no oxygen at all when she is bleeding.
Okay, ma'am. What about the drugs, ma'am? What drugs should be avoided during this?
Nothing. If it is a life-saving drug, is required. Suppose there is a snake poisoning. The venom has to be given. Anti-venom syrup. Suppose the patient, actually rabies, the patient will not go for shock. Anti-rabies vaccine also is important because it's a life-saving drug.
Yes. Ma'am, there are conditions where this osteoporosis come into role, ma'am. Whether if the pregnant woman is having this osteoporosis, what should be the management or what should be the precautions for that woman to take or during
In
pregnancy?
reproductive age group, osteoporosis is very, very less because the estrogen is there. I don't think in reproductive age group, the osteoporosis is going to play a big role. And the estrogen, she has become pregnant, that means sufficient estrogen is there. The fall is not due to osteoporosis.
Okay. Fine.
If the patient is on premature ovarian insufficiency, and if she has conceived after a long time, premature ovarian insufficiency, and she has conceived with the donor ovum, then there may be a chance for osteopenia. So by then, they would have evaluated her when she is taken up for ART and other things.
Yes, ma'am. Ma'am, there is no other questions in the chat box, ma'am.
That means nothing is entered.
Ma'am, if you allow us, then we can end the webinar for today, ma'am.
Okay, thank you.
Thank you, ma'am. Thank you for that informative session, ma'am. Ma'am, I requested you for your blogs for our Shield Connect webpage, ma'am. So if you have any blogs or if you have any papers, then we can share with us, ma'am.
Okay, only after November. I have a conference in October, so
Okay, ma'am.
November we will do. Okay.
Sure. Thank you. Thank you, audience, for your active listening, and I would like to thank our Shield team for making this webinar.
Can I leave?